to kind of get started, for those of you who don't know me, I'm Jayson Marwaha. I'm a minimally invasive surgery fellow at the University of Michigan. I appreciate the ability to kind of kick off this panel because I've been fascinated with surgical data science and its applications like AI for several years now. Oh, perfect. All right, so the slides are up. Excellent. So, I was given the huge and very daunting and almost impossible responsibility of essentially explaining in the next 15 minutes what is surgical data science, which of course is a vast topic, but it's not only vast, but very rapidly evolving, by the day, and in some cases, by the hour, depending on what day you're looking at. And so I actually wanted to take a step back and start by defining some of the absolute broadest concepts. Sorry, I'll skip ahead. There we go. Start by defining what even is data science. Of course, we all know what surgery is, but what do those latter two words mean exactly? And I think the best way to do that is actually to start by telling you briefly about, a story about arguably the world's first ever data scientist. And that story actually goes, interestingly, back to the 1500s. So back in the 16th century, philosophers at the time were proposing all sorts of totally wild theories about what they thought the solar system and the universe looked like. And, one theory at the time, one prevailing theory was geocentrism, which is the Earth is at the center of the universe. But there were many other, actually even wilder theories being proposed at the time, and philosophers were frantically trying to prove their theories. But there was one man by the name of Johannes Kepler who decided to take a very different approach. And so instead of starting with his own theory, he decided to approach the question with data. And so he actually got his hands on the largest data set, actually probably the only data set at the time of planetary motion. And actually, as the story goes, he got that data set by kind of stealing it red-handed from the Danish government at the time, which is not part of a data scientist's job description now. But he stole that data, and then he spent over a decade analyzing this data set. And finally, after several years, using what we now call logistic regression, was able to prove in his seminal book, Astronomia Nova, that planets orbited elliptically around the sun, which is one of what we now know as Kepler's laws of planetary motion. And so I think traditionally, data science in the way that we have always thought about it, science, traditional science in the way that we've always thought about it, has been a matter of trial and error, of idea and experimentation. You come up with a theory, and then you try to experimentally or perhaps empirically validate it. But this new and emerging field of data science actually turns that model on its head somewhat, where you often start not necessarily with a hypothesis, but instead you start with lots and lots of observations from the natural world, and you try to extract, insights or truths from it. And so now let's shift our context window back to surgery. And I think one of the first questions that we have to consider is, what does clinical decision-making look like in the absence of surgical data science? So this is actually one of my favorite papers. It's from a well-known behavioral economist at the Harvard Kennedy School who studied how cardiac surgeons make complex decisions. And what he actually showed is that, or one of his findings rather, was that surgeons make very different treatment decisions based on whether a patient is 79 years old and their birthday is in 2 weeks versus patients who just turned 80 and their birthday was 2 weeks ago. So these patients are actually technically only 4 weeks apart in age, and therefore, I would argue, are physiologically equivalent. And yet, I think in part because of the limits of what we know about these patients and how their clinical characteristics affect their outcomes, we think about them and treat them very, very differently. There are lots of other innumerable famous examples in the literature. This is a famous paper from several years ago from Science that point out other kinds of mental shortcuts that we make when we're delivering procedural care, just because of the sheer amount of data that we have to grapple with. And people often say that these mental shortcuts or heuristics exposes some of the cognitive limitations of human clinical decision-making. But what I actually think is that what this exposes is the limitations of the data that we have access to to make more precise and personalized recommendations and decisions for our patients. And so this sort of realization that we should be gathering more data from our surgical interactions and trying to extract insights from that data started actually many, many years ago, and more recently has evolved to include discussions around using things like ambient sensors in the operating room. Because, for the longest time, the operating room has been essentially a data vacuum, or as this famous data scientist, Li Feifei, has described it, a dark space in healthcare, just because of the difficulty of extracting and studying objective data from surgery. So that's kind of where this conversation started. But of course, in recent years, there's been a tremendous influx of new digital tools that we're all familiar with now in the operating room, which is now passively collecting a lot of this data. And there are lots of examples of ambient sensors in the operating room and other kinds of digital tools. But of course, the most prominent example, which I don't need to dwell on because we're all familiar with it, is of course the surgical robot. So, the surgical robot has seen tremendous adoption, of course, not only in general surgery, but in many other specialties as well. And the second order effect of this very rapid rise of robotic adoption is, of course, that we now have a digital platform to capture all kinds of new data streams, types of data that didn't exist before, and then also types of data that were generated but we were never capturing. Things like surgical video data, of course, but also kinematics and instrument use and haptics and much, much more. And these kinds of digital platforms, I think, have made the concept of surgical data science, which is fundamentally the task of extracting insights from large-scale surgical data, much more possible in recent years. And so the kind of next chapter of my time up here that I want to dedicate to is talking a little bit about applications of surgical data science. And I won't dwell too much on some of these examples because I think future speakers and experts on the panel will be focusing specifically on each of these applications. But I do want to touch on some representative ones. So I think one insight that can be gained from surgical data science that is very, very important is an incredibly granular understanding of the significance of what transpires during an operation. And I think this paper is the landmark example of this phenomenon. It's a study from the well-known surgeon scientist and urologist Andrew Hung at Cedars-Sinai. And in this study, he essentially studied how surgical gestures during an operation are correlated with postoperative outcomes. And so on that, on this figure, in the top right-hand corner, what you see is that each row is a surgery and each color is a gesture. So essentially, each row is a surgery and its sequence of gestures. And what he found in this paper is that certain signatures of surgical gestures are associated not only with postoperative outcomes, but with 1-year patient-reported outcomes. And so I think it stands to reason that understanding this connection between intraoperative gestures and outcomes can be a very powerful tool, and it's actually quite literally the underpinning of how we improve things like surgical education, feedbacks and skills assessment, and predicting outcomes, which again all of our other panelists will be addressing in a little bit more detail. I think another broad category of very exciting applications of surgical data science is the ability to build a very wide variety of helpful and exciting tools using this new and innovative but very data-hungry technology that we all know as AI. And these kinds of tools include things like clinical decision support tools, of course, to ones that can automate mundane tasks. And some prominent examples that I'll point out of this are the cholecystectomy go, no-go model from our hosts, Amin Madani and Dan Hashimoto, which I think by now has become a very widely known and well-respected example of how to apply principles of AI and data science to intraoperative clinical decision support. And what has followed in its suit actually is many similar computer vision tools that have cropped up since from research labs and private companies as well. So I'll move on briefly to some other exciting applications of surgical data science, which are tools that could do things like automatically dictate operative notes from surgical videos, which has been proven to be technically possible, and technologies that even have the potential to automate or act independently during portions of an operation. Now, I think that these kinds of applications are much, much further out from clinical application, but they have, again, at least shown to be technically feasible given enough data and the right modeling. But to make all these applications part of our routine clinical practice at some point in the future, there is a very, very long list of challenges that the surgical data science community is currently actively grappling with. And so I'll spend this final portion of my time going through some of those challenges. One challenge that you have undoubtedly heard of is that is a technical challenge to making these tools better is data. Everyone talks about how we need more surgical video data, we need more intraoperative data, but I want to kind of put a fine point on this dilemma and talk specifically about what kind of data do we need and how much data do we need. And so there's this widely accepted principle, borrowing from other disciplines, this widely accepted principle from computer science, coined by a famous computer scientist, Richard Sutton. And this principle is called the bitter lesson, which is the concept that if you want to solve any kind of problem, an approach that includes massive data and massive computation will always outperform approaches that involve human domain expertise. And this principle, which he first described in 2019, has since been proven over and over again. So as examples, Deep Blue, the IBM chess algorithm from many decades ago, was actually never taught the rules of chess. AlphaFold, the famous algorithm from Google that predicts how proteins will fold, was never taught our mechanistic understanding of how proteins fold. And perhaps the best known example is large language models. They were never taught the rules of English. They were never taught grammar. And yet all of these models developed superhuman capabilities just from watching more chess matches or watching more proteins fold or reading more text than what any one human could do in a lifetime or actually in several lifetimes for that matter. And so to translate that concept to surgical data science, I think what that means is not that we need highly curated data sets of videos from like the world's foremost surgeons, but instead what we need is all kinds of surgical video, good and bad, but most importantly at a scale that is massively larger than I think any one researcher or any one institution has right now. So to move on to another challenge, once this challenge of technical feasibility and data interoperability and data bottlenecks has been solved, the next challenge will be one of surgeon calibration and surgeon trust in these new tools. And specifically, what role should these tools play in quality improvement, in education and feedback, in even real-time intraoperative decision support. I think the question that ultimately needs to be addressed in this topic is how do we design these tools in a way that they communicate information to us in a way that actually makes us want to heed their advice instead of just dismiss them like another pop-up or another best practice advisory. And then, if we are going towards a future where we will ultimately at some point soon be seeking advice from these models, then that leads us to a third challenge, which is the challenge of liability. Now, interestingly, this is actually a topic, liability, where there is a fairly clear answer that exists right now, but to be honest with you, a suboptimal answer. And which is that physicians right now are ultimately liable for any patient harm, regardless of the tool that was used to deliver the care. The problem with this very overly simplistic answer is that it unfortunately discourages us from ever really adopting promising or innovative tools at scale. However, a follow-up point that I want to point out is that just in the last couple of months, there started some early signs have emerged that this dogma might be changing soon. And so as an example, JACO, or the Joint Commission, just recently within the last couple of months published new guidelines on the use of clinical AI, which suggest that hospitals should in part perhaps be held responsible for making sure that the tools that their physicians have access to are reliable and trustworthy, and thereby shifting some of that liability potentially off of individual physicians for, say, heeding the wrong advice. And so but as you can imagine, that implication of shifting liability towards institutions as opposed to individual physicians comes with some very complicated implications of its own. Because if every hospital now has to tightly regulate its own ecosystem what are the implications of that? Does that mean that every hospital, big or small, now all of a sudden needs to stand up their own independent expert AI vetting committee? This brings us to the next challenge, which is a challenge of governance, which is essentially the challenge of making sure that these complex and delicate and ever-evolving tools are safe and effective throughout their life cycle. Because, because of the impracticality of having every hospital vet and monitor every tool that their physicians have access to, there have been some recently proposed solutions that try to address governance in perhaps a slightly more practical way. And so one of these proposed solutions is to, quite simply, designate certain centers throughout the country where these tools will be evaluated and hospitals then can learn from their studies. And I think another proposed solution that has largely come from industry is simply to automate the governance process itself with AI. And this is actually something that many startups have cropped up to start doing, and also the FDA has also started to incorporate this into some of their regulatory decisions as well. And so to wrap things up, there are many other topics that I think need to be grappled with to make surgical data science, a routine part of our clinical practice that I quite frankly, don't have the time to touch on. Fairness, bias, data ownership, privacy, and security. But I think the central unanswered dilemma is one ultimately of professional identity. What happens to us as surgeons when our performance becomes quantifiable and comparable? What do our jobs look like in a future where data science tools are not only constantly telling us what to do, but also telling us what we should have done? I think for better or worse, while these are the questions that are the most central, they are also the ones with the least clarity right now, and therefore, I think, hopefully, the greatest opportunity for us to define the answers for ourselves. And so I want to end on this very prescient quote from a paper, in Science from the 1950s. And I think this paper is now widely regarded as the first study that demonstrated the promise of data science in medicine, because it showed that analyzing large-scale clinical data sets can produce insights that add tremendous value to specialist decision-making. And so I think what makes surgical data science most exciting right now is that its potential has been very clearly recognized for a very, very long time, but we're finally starting to have the tools to actually enable it. So thank you.